Sciatica is a clinical syndrome caused by irritation, compression, or inflammation of the sciatic nerve or its roots. Not a disease itself, it's a symptom complex. Typical presentation: pain radiating from lower back, buttock, posterior thigh, leg, foot, electric shock-like in quality. Aggravated by sitting, walking, coughing, or sneezing. Clinical significance: understanding the anatomy of the nerve is key to localizing lesions and guiding treatment. Definition: high yield. Sciatica equals pain along sciatic nerve distribution. Characteristics: radicular, nerve root, pain. Usually unilateral, movement, sensitive. Worse with flexion, coughing, sneezing. High yield tip: radicular pain equals nerve irritation. Local muscular pain does not follow a dermatomal pattern. Root value and formation: nerve roots L4, L5, S1, S2, S3. Formation: these roots form the sacral plexus. Largest branch: sciatic nerve. Clinical correlation: most sciatica cases are due to L4 to L5 or L5 to S1 disc prolapse. Memory tip: sciatic nerve equals L4 to S3, highway for leg nerves. Origin and course of sciatic nerve. Origin from lumbosacral trunk, L4 to L5, plus sacral plexus, S1 to S3. Forms in the pelvis, anterior to piriformis. Pelvic course: lies on piriformis, coccygeus, internal obturator muscles. Clinical correlation: piriformis spasm, compresses sciatic nerve, piriformis syndrome. Memory tip: piriformis equals sciatic bottleneck. Exit from pelvis: exits via greater sciatic foramen, usually below piriformis, variations through piriformis. Early division into tibial and common peroneal branches. Clinical tip: variations can predispose to compression or unusual pain distribution. Gluteal region lies deep to gluteus maximus, midway between greater trochanter and ischial tuberosity, injection danger zone. Avoid IM injections in this region to prevent iatrogenic nerve injury. Thigh course runs down the posterior thigh, lies on adductor magnus, and covered by hamstrings. Termination at the upper angle of popliteal fossa divides into tibial nerve, common, peroneal, fibular, nerve. Branches and functions: motor supply, hamstrings, semitendinosus, semimembranosus, biceps femoris, long head. All muscles below knee via tibial and common peroneal branches. Sensory supply, indirect. Posterior thigh, entire leg, via branches. Sole of foot, clinical tip: weakness or sensory loss, helps localize root lesions. Dermatomes and radicular pain root. Pain distribution: weakness, reflex, gait, abnormality. L4, anterior thigh, medial leg, knee extension, knee jerk, knee instability. L5, most common, lateral thigh, dorsum foot, big toe, dorsiflexion of foot, normal foot drop, high stepping gait, S1 posterior thigh, calf, lateral foot, plantar flexion. Ankle jerk, cannot walk on toes. Memory tip: L4 equals knee, L5 equals foot up, S1 equals foot down. 7. Myotomes and gait abnormalities. L5 lesion, foot drop, loss of dorsiflexion, high stepping steppage gait. S1 lesion, weak plantar flexion. Patient cannot stand on toes. Push-off phase is weak, antalgic gait. Shortened stance phase, patient leans away from affected side due to pain 8. Clinical tests: straight leg raising, SLR, Laseg test. Patient supine, leg raised passively, pain between 30 to 70 degrees. Positive indicates L4 to S1 nerve root irritation. Crossed SLR test. Raising normal leg reproduces pain in affected leg. More specific for disc herniation. Slump test. Seated patient, spine flexed plus knee extension. Reproduction of pain. Neural tension. 9. Common causes of sciatica. Spinal causes: intervertebral disc prolapse. Most common, L4 to L5, L5 to S1. Lumbar canal stenosis, spondylolisthesis. Extraspinal causes: piriformis syndrome. Pelvic tumors, pregnancy, iatrogenic, IM injection injury. 10. Differential diagnosis, condition. Key difference: sciatica, radicular, dermatomal pain, facet, joint pain. Localized, non-radiating, hip pathology. Pain on hip movement, peripheral neuropathy, stocking glove pattern. 11. Summary, take-home points. Sciatica equals nerve root problem, not muscle pain. Root value, L4 to S3. Most common cause equals disc prolapse. L5 lesion equals foot drop. S1 lesion equals loss of ankle reflex. SLR test is key bedside test. Gait changes provide strong diagnostic clues. Don't forget to like this video, comment your questions or clinical experiences. Subscribe for more high-yield clinical anatomy videos.